The Curbsiders addiction medicine is for entertainment, education, and information purposes only. The topics discussed should not be used to diagnose, treat, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the hosts and should not be interpreted to reflect official policy or position of any entity aside from possibly Cashlack Memorial Hospital. In short, we aren't responsible if you screw up. Please do your homework and let us know if we got something wrong.
Welcome back to the Curbsiders Addiction Medicine, our mini-series on substance use disorders. I'm Dr. Carolyn Chan, and today I'm joined by my co-host, Dr. Zena Huxley-Riker and Dr. Sean Cohen. On tonight's episodes, we are going to be discussing adulterants in the drug supply, specifically xylazine, and chatting about how we can care for xylazine-related wounds with Dr. Raagini Jawa and an incredible nurse practitioner, Tehya Johnson. But before we get started, Zena, will you remind the audience what we do on this show?
Of course, Carolyn. We are the addiction medicine podcast that uses expert interviews to demystify common addiction medicine topics, reduce stigma, and inspire listeners to be fierce advocates for all individuals who use substances.
And of course, this podcast is brought to you by our partners, the American College of Academic Addiction Medicine. ACAM offers a wide variety of products that can help support your professional development and career journey. So stay up to date on the latest in addiction medicine with the Professional Practice Bundle, or ensure that you are ready to pass the ABPM board exam with ACAM's Board Prep Bundle. ACAM has the resources you need to excel in academic addiction medicine through networking, fellowship opportunities, educational resources, and so much more. So visit ACAM at acam.org.
Tonight, we have a wonderful conversation with our guests, Dr. Raagini Jawa and Tehya Johnson. Dr. Raagini Jawa is an assistant professor in the Center for Research on Healthcare at the University of Pittsburgh. She's board certified in internal medicine, infectious disease, and addiction medicine. She provides office-based addiction treatment, endovascular infection specialty care, and xylazine wound care in Pittsburgh. Her research studies implementation of harm reduction services within health settings and strategies to mitigate infectious and non-infectious complications of the changing drug supply. For fun, she performs Bollywood covers on her ukulele. Tehya Johnson is a nurse practitioner and primary care provider and fierce advocate for harm reduction and drug user healthcare. She is the Associate Medical Director of Harm Reduction at Boston Healthcare for the Homeless and is affectionately referred to as an outside cat due to her passion for street outreach work. She deeply enjoys providing education related to her work, most especially about wound care and compassionate overdose response. In today's episode, we learn how to talk to our patients about their wounds, when to use antibiotics, how long, what antibiotics to use, and really how to offer the nitty-gritties of wound care in our offices, what products to use, how to partner with our patients to effectively care for xylazine-related wounds. So without further ado, let's get to it. And as a quick warning, today's episode is adulterant rated.
We're so excited to have you guys here, Raagini and Tehya. This is the lightning round where we are really excited to ask some rapid fire questions to get to know both of you better. So let's start with you, Raagini. Do you mind giving us a one-liner to describe yourself?
Sure. I am an infectious disease and addiction medicine doc by day and a ukulele Bollywood singer by night. Trying to help get harm reduction into healthcare with my research.
Does the ukulele and Bollywood go together?
Absolutely. Oh, yeah. It is a Bollywood ukulele passion over here.
Are you the first person to mix those two things together?
Probably not. But I was the first person to have that as an account.
And that is important.
Is there like a piece that you're working on learning to play right now?
No, I enjoy music. That's like my therapy when I'm not at work. So whatever gets stuck in the head comes out.
And Raagini, what is your favorite aspect of, or some favorite aspects of working in addiction medicine?
I really appreciate being a one-stop shop for my patients in many ways. I think that oftentimes patients with substance use disorders or who use substances have to jump through hoops, and it's nice to be able to provide primary care, infectious disease, and addiction medicine in one place. So, and build long-term relationships with patients and really see them through every phase of their disease or recovery or whatever. And I really appreciate that long-term relationship building.
I'm jealous that you can add an incredible layer of ID knowledge because there's so many days where I'm like, man, I wish I did another fellowship, but probably not really. So it's incredible that you can offer that to your patients.
Listen, I hear you.
And Tehya, it would be great to get to know you a little bit better. Can you give us a one-liner about yourself?
Yeah. So I am a former research scientist turned nurse practitioner who works at the intersection of people experiencing both homelessness and substance use disorders. And I spend most of my time out in the street. And then I'm also a full-time mom with a very, very fiercely independent 6-year-old who deeply enjoys being outside, which is good for me because I love being outside.
I love that. Already fiercely independent. I can't imagine 6 years old. I have like a 3.5 and a almost 1-year-old, and it's just like they change so quick. I'm like, you're already becoming little humans, so I can't imagine what they're like at 6, to be honest.
Yeah, it's both exciting and terrifying.
And how'd you wind up in addiction, or kind of at the intersection of addiction and kind of medicine for people who are unhoused too?
So my undergrad work and then my post-undergrad work in research was all addiction related. So I was doing neural pathway research around addiction and negative stimuli in the brain. But preclinical work is a very stressful, weird place where you feel so far from doing anything actually like impactful on many a day. So I had a best friend who was a nurse practitioner. She was loving it. I knew I didn't want to go to medical school. I love my fellow doctors, but my best friend, I just absolutely loved the way she worked and the freedom she had. So yeah, I went back to school to be a nurse practitioner. And my daughter was 7 weeks old when I started, so it was quite a journey.
Wow.
And here I am. But yeah, I absolutely love the relationship building. I spend most of my week on the street, and so my work is really informed by the community I serve, and I feel deeply, deeply lucky to be able to do that.
Well, we are so lucky that you decided to make the switch. It's always really cool to hear everyone's pathway. I feel like people get to the field in such different ways. It's really great to see and hear. Zena, do you mind kicking us off with our first case from Cashlack Memorial?
I would be delighted, Carolyn. All right. So you're seeing patients in your primary care-based addiction medicine clinic. Your last patient of the day is Mrs. Z, a 32-year-old female with a long history of opioid use disorder and cocaine use who you have recently started on buprenorphine. She's feeling okay on her buprenorphine 24 milligrams daily, but still has some cravings and some withdrawal symptoms, so has continued to use heroin or fentanyl as well as cocaine. You notice that it looks like she has some sort of ulcer on her forearm that you haven't noticed previously, and you're worried that this may be related to xylazine. So, Raagini, do you mind starting us off by just telling us a little bit about xylazine, what it is, how it works?
Sure. So xylazine, or tranq, it's a non-opioid alpha-2 adrenergic receptor agonist. It was FDA approved as a veterinary grade procedural tranquilizer in the 1960s. But when we started seeing it in the street opiate supply was really in the early 2000s, and it was noted as an adulterant in heroin or used in conjunction with heroin in Puerto Rico. And when we saw it more in mainland US was closer to 2018, 2019, where it was sporadically detected in the Northeast, and up in particularly concentrated in places like Philadelphia or other areas in the Northeast. And so in 2023, xylazine was found in 98% of the illicit opiate samples in Philadelphia. So it's really over the course of just a couple of years, we've seen it as increasingly adulterating the illicit opiate supply. And, we talk about like, what is alpha 2 adrenergic receptor agonists? Like I think back like, oh gosh, medical school, what does that do? And so it causes central nervous system depression. It has some sedating properties. It has some pain relieving properties and some muscle relaxant properties. But there's some interesting new data out that it might have some activity in not just the alpha 2 adrenergic receptors, but also the kappa opiate receptors. And we really need more research on humans because what we know is from veterinary sciences. So, yeah, that's xylazine.
And so, like, I guess, I mean, this is maybe a loaded question, but like it went from like just being very localized, it sounds like in Puerto Rico, and took 20 years and then just kind of took off around Philly. Is there any idea on like why or like what drove it to just become so widespread?
It's a great question, and I'm not sure. And I think, unfortunately, because we don't have universal surveillance in our nation of the changing drug supply, we really find out about drug trends when it starts harming people and we start seeing them in our own clinical practice. So we saw similar trends with fentanyl coming into the illicit opiate supply and sort of becoming the predominant opiate, replacing heroin. And so other adulterants have done similar things. And so we've seen these sporadic detections in the Northeast, and then we've sort of seen over time, over the last couple of years, it being more and more detected in drug seizures. And we have some of that data through the DEA. I wish I knew, Sean.
And I'm curious too, Tehya, you do so much harm reduction. What do you hear from people with lived experience in terms of just how having xylazine in their supply kind of like changes the experience, maybe their patterns of use? What are we hearing on the ground from people who have experience with this?
Yeah, up here in Boston, it's not as prevalent as it is down in Philly, but we are looking right now at about like 30 to 40% of our supply having xylazine in what at least is being tested. But on the ground, people are really concerned about how long they're sedated, that they're not expecting to be out for the amount of hours that they are out after using. We have a lot of people coming in concerned about their peers too, who sometimes it seems as though people right after they use go out fairly quickly compared to fentanyl or heroin. And so this has been a huge concern for people. And then, of course, with overdoses, not necessarily longer in the sense of the respiratory depression lasting longer, but more so the overall time it takes from the beginning of a response to when someone is actually conscious. So we often talk about how we're not necessarily using more naloxone, but we are having to use oxygen for longer and finding safe spaces for people to go because they just seem to be unresponsive to some of the stimuli that we use, such as like a sternal rub, for much longer periods than we've been used to in the past few years.
I'd love to sort of chime in too. I think that for many of the patients I care for who are being exposed to xylazine, many don't know that they're being exposed to xylazine. They think they're purchasing an opiate or fentanyl or heroin and are finding out that it's contaminated or adulterated in their supply. And a disproportionate amount of my patients dislike the sensation, and they're really worried about either the risk of having negative clinical downstream effects or becoming dependent on a drug that they weren't intentionally seeking.
Yeah, I guess to that point of just folks not knowing necessarily what is in their drug supply, when you're talking to patients, do either of you have any like tips or specific clinical history or lab tests that may be helpful for us to talk with patients about how to know if they're being exposed to xylazine?
So our patients are the experts in their own body, and because they're the ones who are experiencing the changing drug supply firsthand, getting a really good clinical history is key. And so asking folks like, how does it feel after you've used your drug? Has anything changed? How about, are you feeling more sleepy than usual? Are you having periods where you're passing out and then waking up several hours later? Have other people in your community been complaining about similar symptoms? I mean, these are some sort of secondary markers that we can really rely on. Self-report is important here, because we don't have ample human sample testing or local drug testing in many communities. But so I would say the number one thing is talking to people, figuring out, do they have typical sort of exposure symptoms? Have they heard about it in their community? And then I think we have other things in our sort of medical wheelhouse, which is like human sample testing. So sometimes people have gone to a hospital where they have had a comprehensive urine drug screen where a provider may have actually tested for things like xylazine. And so that might be the first time a patient will find out that, oh gosh, I was exposed. But that's far in between right now. I think that there's not sort of universal UDSs that test for all the battery of adulterants in our supply. And oftentimes it takes a couple of days, depending on where that lab is sent out. So it might not be a practical indicator of exposure.
For sure.
I know that xylazine test strips are now available, sort of similar in many ways, similar in principle, I think, to fentanyl test strips, but I actually don't know a ton about them. Like how good are they? How sensitive, specific are they? How useful are you guys seeing them be for patients?
The xylazine test strips are, they're tough right now. There's a lot of variability. You have to be pretty precise about how you're diluting your substance. And so when we do trainings together, we talk a lot about making sure that you're checking in with the manufacturers about exactly what needs to happen to give the best result. And this can be really difficult for clients, especially if you are using out in the street and you maybe don't have a lot of time. These are things that we consider often. We're very lucky here in Boston. Our SSP has really great, like on the ground, low threshold drug testing. You can bring very, very small amounts. So we really encourage people to actually just bring their samples right over next door to AHOPE. They're literally in the building next to us, and very soon we'll be in the same building together. But that's not often the case. So I think encouraging people to use the test strips, if you have the availability, is key. But just thinking about the kind of different considerations when it comes to the use of them. I think my clients right now kind of are assuming every negative thing they're experiencing has to do with xylazine. And it's been difficult to kind of tease out what may be the xylazine versus something else. And our best course of action really is to get that confirmatory testing.
Xylazine test strips, almost similar to fentanyl test strips, require a state to decriminalize drug checking materials. And so it's really important to know what your local laws are, because it's not necessary that you are in a community where it is legal to distribute xylazine test strips. But if you are in a state where they have broader sort of political will and laws for drug testing equipment, they're a potential harm reduction strategy. And at this point, we have several commercially available xylazine test strips. They all range, like Tehya said, in cost and dilution ratio. And it is really important to understand what your local validation testing is reporting about how good they are, because they're really dependent on how you use them, how much you're diluting your drug, how much drug you're actually using to test. And there's a possibility of false positives, particularly with cross-reactivity to specific agents, but that changes depending on which xylazine test strip you're purchasing. So I distribute xylazine test strips in my clinical practice and talk to my patients about testing their opiates rather than other like stimulants and whatnot. And knowing the limitations of xylazine test strips, it's a harm reduction strategy that you can potentially use to know like what might be in your supply, but they're an imperfect tool.
Good pitch and argument too for know your local resources, but also like chance for advocacy is like the drug supply is dangerous because we don't know what's in it. In terms of like going back to our patient, kind of on the more chronic side, it sounds like, can you tell us a little bit about kind of xylazine wounds? And this might be more for Tehya first, but what do xylazine wounds look like visually? Kind of what do you expect to see? Are there any like particular areas of the body you usually see them?
Yeah, it's a really good question. So generally we see that xylazine wounds kind of start off as like a discoloration of the skin, often purplish. And these areas that are affected end up opening up in the skin, and you may see like very small wounds or very small ulcerations. We sometimes see people coming in with like scattered patterns of these small wounds across an extremity. Oftentimes it's either the upper or the lower extremities, and less so like the trunk. Even the hands are often seem to be not affected as much as the actual arm or the actual leg. And over time, these wounds can then coalesce into these larger ulcerations that are kind of the more typical presentation people are used to. And I think right now we're still kind of seeing people at that stage where they are at the point where it is a larger ulceration because, going back to advocacy, we really need to be advocating for really safe spaces for people to trust the medical system and believe that they can come to us at those early stages where we can begin to treat them before they coalesce. But it's really tough. I think something we hear from people often is that these wounds are really representative of their use, and that kind of internalized stigma, the shame, it's like a physical representation of that. And it's really difficult for even someone that they may trust to show them something. It puts you in a really vulnerable place. And so what we do often is our wound care is the place where we engage with people the most. It's really where we try and make it as comfortable and as non-judgmental, beyond pretty much anything else that we do, because it is so sensitive. And we really want people to be coming in when they have those, those smaller wounds or those discolorations or, again, anything atypical. But oftentimes we are not seeing people until that really large area of the body is affected.
Give us your best tips. How do we do this? How do we welcome and invite patients in to help build trust?
Yeah, I think when people initially show, no matter what the stage, oftentimes we have noticed that these wounds have a very strong odor to them, or that their appearance is, pretty severe looking. And this has been documented for a while. There was a 2011 paper that came out from groups in Puerto Rico talking about this very strong odor. And that is really a barrier for people coming in oftentimes. It's kind of the appearance and the color or the odor. And so when people come in, just making them feel really comfortable, no matter what they're presenting with. We have a really nice like lazy boy recliner chair for wound care. We make sure to get lots of snacks, getting lots of supplies ready ahead of time so you're not kind of bouncing between your wound care supplies and your patient, that you're there and you're present with them and you're making them feel comfortable through the whole thing, no matter what is in front of you, is really key. And just the education piece too, including them in the care that you're doing, talking to them about when the last time they had a dressing change was, what they're able to tolerate when it comes to wound care supplies, making them as involved in their care as much as you can. It makes people feel comfortable and makes it seem that their knowledge about their own body is just as important as the knowledge that you're trying to give them.
Yeah, I've gotten to learn a lot more about wound care during this year of my fellowship, and I think it is so hard to talk about with patients for understandable reasons, but also when you sit down and do the wound care and like that relationship that you can build with a patient is pretty incredible. I guess stepping back even before you get to the wound care, is there do either of you have specific ways that you ask the initial question about whether someone needs wound care, if they're worried about anything that is happening on their body?
I just open it up to say, is there any spots on your body or parts of your skin that you're worried about? Any funny lesions or ulcers or sores or anything like that? I think not using medical language for our patients is really important. So do you have any black spots or pimples, or if you say necrotic ulceration, I'm pretty sure people will be like, no. So I think just being, do you have any spots or parts of your body that you're worried about? And then if they say no, knowing that there's so much stigma and self-shame and sort of anticipated and experienced barriers to accessing healthcare, I think normalizing the fact that, hey, I'm taking care of other patients who might have had things like xylazine wounds. Have you heard of anything like this? Or do you know anybody else who has this? And then that opens a conversation. And once the conversation opens, I've noticed like the floodgates open, that it'll be like, well, oh my gosh, thank you for asking. Actually, I have had all these wounds on my body and I've been trying to figure out how to take care of it and tried XYZ and it hasn't worked and it's been so frustrating. And I mean, it's really eye-opening. But, it's even in the hospital when a patient is coming in with whatever non-drug related reason or some other complaint, I often didn't do a full dermatologic exam until now, where I'm like, okay, let's talk about it. Can I examine all of your skin? And getting permission, because it's, again, not everybody is ready or interested in talking about their wounds. And that's okay, because every time you have an encounter, asking the same way with kindness and empathy shows that you're interested and that you're a trustworthy provider. And then, slowly you can, some patients who have experienced much more healthcare trauma will open up.
So we follow your tips and you ask permission to speak about her skin. And she shares that in the past few weeks, she has finally really noticed these large wounds sort of appearing on her forearms and her legs. Some are in places where she injects and some are in places where she doesn't. And she tells you she's really embarrassed about the wounds and doesn't know what to do about them. She hasn't had anything like this before and is always really careful about infection prevention when she's injecting. And you take a look at her skin and she has these 3 large shallow-based ulcers with minimal drainage and various forms of eschar. They vary from about 8 centimeters to 15 or 16 in length. So just talking through, like when you're looking at a wound and doing an exam, like what are some what are some like red flags? What are some things that you're thinking about or worried about where it would really point you to say, hey, I should really help support to get this person to the emergency room where they can get some additional support?
I think first differentiating like whatever red flag symptoms I may be seeing, what kind of is the severity of these red flag symptoms too? Like, is this something I'm going to be able to treat on an outpatient basis versus the ED? Because readiness is a huge thing. And in talking about barriers with your patient, especially when it comes to whether or not they're able to go to the hospital, whether that's transportation or deep fear of the treatment that they have previously experienced at the hospital, I think that is first and foremost something that you need to talk about with the client. And I often do that even before I start in with like, hey, I think you need to go to the hospital. I'll just be like, hey, if I said you needed to go to the hospital, like, how are you feeling about that right now? But if I'm seeing something pretty significant, pain, tenderness, swelling, redness in around really purulent drainage of a wound, especially if we're near a joint or they're expressing that the level of pain they're experiencing, even when they're using, is more than baseline for a typical wound that they've experienced. These are all indications that I'm thinking, okay, we need to think about antibiotics and we need to think about whether or not we need to get to the hospital. We also are very lucky to have point of care ultrasound on at reach with us. So oftentimes we'll see, can we use that? Is this something that needs to be drained or, how deep is this? If it's over a certain depth, I'm thinking hospital versus not hospital. There's a lot of different considerations, but first and foremost, just talking to the patient, like if this is what is necessary, like how are we going to work with you on this?
POCUS, another fellowship that at times I've contemplated may be very useful and then say, no more.
I think it's interesting talking about wounds, and I acknowledge the fact that like even in our medical training, we did not get wound specific training. So we often have this like visceral response, like, oh gosh, we have to send somebody to the emergency room. But, you might be working in a low barrier setting in a harm reduction organization, in an addiction clinic. A lot of these wounds can be adequately treated in an outpatient setting. And so I think sort of understanding that the triage and the urgency, the visual severity of the wound doesn't necessarily equate to somebody needing inpatient management of their wound. Oftentimes, doing a trial or staged approach from in an outpatient setting, then watching for red flag symptoms and then building trust with patients is probably a better way to go about this, in my opinion, than sending somebody to the emergency room where they may have already experienced a lot of like weight and stigma and other barriers,
I mean, just talking a little bit about red flags and say this person like not systemically ill, doesn't need to go to the emergency department right now. What points you towards, I need to trial this person on oral antibiotics and see kind of if that helps us out?
So like Tehya alluded to, these wounds often are chronic and they're chronically, like wounds are just chronically colonized with bacteria. So and they often will have an odor, maybe will have some drainage, and that is the norm. And that is just like the biofilm of the wound. And keeping them clean and covered is good prevention. And they might go through like periods of increased colonization of bacteria and that. But when you're thinking about a supra-infected wound that requires systemic antibiotics, that's when somebody is having localized painful erythema and induration. Oftentimes it might be around the wound area. It might be even in the wound area. If they're saying that the type of drainage is changing, so it's becoming thicker, is purulent, or the quantity of drainage is increasing where they're saturating multiple dressings a day, that's really the time when you'd be like, oh, I probably should start them on antibiotics. When they start having systemic symptoms, like you were saying, Sean, so fevers, chills, rigors, that's when they probably need to go to a higher level of care. So I think there's this whole old wives' tale where we do topical antibiotics and superficial cultures. And unless, like, I think the go-to is PO antibiotics. If you're worried about a skin and soft tissue infection or a supra-infected wound, empiric staph and strep coverage, which are the typical pathogens in our skin, are the go-to. So if you have we do sort of empiric MRSA coverage and MSSA and strep coverage. So you can do things like doxycycline with cefadroxil or doxycycline with Augmentin. And if somebody has a beta-lactam allergy, you can do Bactrim. And the goal is short courses with like increased touch points with patients. So I wouldn't do 14 days of antibiotics. I would do like 5 to 7 days, watch and wait, see how things are going, talk to people about increased frequency of dressing changes, and avoid things like topical antibiotics and superficial cultures. Like if you really are going to tailor your antibiotic course, you need a deep culture. And that's my ID doc. So I think the goal, you guys, is if you're going to give antibiotics, you have to do it hand in hand with red flag symptoms. So if the symptoms are not improving, people are having joint tenderness, if they're redness and erythema and warmth and is expanding or having systemic symptoms, like we have failed outpatient management, that's when we need to go in-house.
I'm just thinking of something one of the nurses that I work with said once that helps her determine or like talk to her patients about when it's time to go to the hospital is when a client tells her, I just keep trying to get off E and it just doesn't seem like no matter how much I use, I'm never off E. Like I'm still feeling that nausea, that like body aches, just overall really terrible no matter what I do, is kind of one of those times where she's like, okay, we gotta call Tehya and maybe we need to just go to the ED right now. But which I thought was really interesting. It makes a lot of sense.
Yeah, that all makes a lot of sense and probably good practice for wounds outside of xylazine-related wounds as well. So going back to our patient, so Missy has some pain at the site of her wound, but she doesn't have any surrounding erythema, no systemic signs of infection. She doesn't really have any purulent drainage or fluctuance that makes you worried about an abscess. So you bring up to her that these wounds may be from a contaminant in the drug supply called xylazine. I guess just thinking about now that we've gotten to this point with our patient, that she's shared her wounds with us, we've taken a look at them. I guess, Tehya, do you mind just like walking us through how to think about the process of caring for a xylazine-related wound?
I think when
A
it comes to
$1,000,000 question.
right? I think something to keep in mind when it comes to wounds really is no matter what the wound is, no matter the cause of the wound itself, thinking about kind of the wound care basics is really important. And something we often say is a dry cell is a dead cell. And so it's about moisture balance first and foremost when we're thinking about wounds. So whether we're seeing a dry wound or a wet wound, that's really what's going to guide the kind of wound care supplies that we're going to use. But before we even get to that point, it's really going to be about how is this person presenting with their wound. So if someone has a covering on it. Oftentimes people come in when it's their first time with a covering over it, and it's something that maybe they found in their environment. And in that case, we want to talk about like what is on this wound right now. If they didn't have access to wound care supplies, there may be something like a diaper or a wet wipe or a paper towel. And we're also asking, when did you place that on top of this wound? Because if it's been several days, things may be stuck, they may be dry, and we want to keep those in consideration too before we start to take anything down. And then secondly, when we are thinking about, okay, maybe there is something stuck to this wound, I want to moisturize this wound to get that off before I can start to do wound care. I want to be talking to a patient about what they can tolerate on this wound. So oftentimes with xylazine wounds, compared to other wounds, they tend to be really tender, really painful. And we've noticed recently that people aren't able to tolerate things that they previously could, such as like the typical wound cleansers that you see in clinics and hospitals. They're all supposed to be non-sting, and we're hearing they're actually pretty painful. They can cause a burning sensation or a stinging sensation, and it takes a lot to make that stop, even when we're using soap and water or saline after. So we've actually been leaning more towards those more gentle cleansers instead of the wound cleansers. But again, talking to your patient first and foremost about what they can tolerate is going to be the first step. So once we have a cleaned wound, we're just going to think about how dry is this wound or how wet is this wound, and how much what we call necrotic tissue is within that wound bed itself. So we're typically seeing with xylazine wounds that there is a substantial amount of necrotic tissue. And then that necrotic tissue is going to be generally that really dark, black, dry eschar, or it's going to be what we call slough or slaw. And that's that kind of yellow tissue that people often mistake for like pus or purulent drainage. So talking to patients about like, this is actually something normal to see in a wound, or talking to colleagues, like this is not necessarily infection. This is kind of typical for a large wound or a deep wound or a chronic wound. It's just compared to other wounds with xylazine, we're seeing a lot more of it within the wound bed, a lot more covering it and a lot thicker tissue. And so
Can I ask just break it down for me? What helps you point to say, hey, this is purulence versus this is like sort of like the slough, like normal slough? Like, how do you differentiate that on exam? What does it look like?
Yeah, the purulent drainage is liquidy. It's gonna be that typical pus consistency versus the slough or slaw is more like kind of fibrinous. It's can often be like really well adhered to the wound bed. So if you're very gently kind of cleansing the wound, say you're using soap and water, kind of doing some mechanical debridement, it's just not going to be debriding. It's not going to be coming off. It's not going to be kind of sliding off necessarily. It's pretty well adhered to the wound bed. It also can be like very shiny. It just kind of sits in place. It doesn't really go anywhere, versus pus is just going to be kind of draining from the wound pretty consistently.
I am showing my how little I know about wound care clearly right now in this moment.
It's very, very common. We hear that question asked all the time. And I do want to also say that as nurses and NPs, like we also don't get good wound care training. Like almost all of the training I had was on the job from previous nurses who were on the street years and years before me. And so, yeah, it's as much about teaching our clients as it is about teaching our colleagues, as we're doing wound care. But that tissue really needs to be debrided off. And so there's a lot of different agents that we can use that debride. Some are kind of over the counter, things that you can buy from like a medical supply without any sort of prescription, versus options that are prescription level. And you do need to connect to a provider who can do that. Is dependent on how much of that necrotic tissue you're seeing in the wound bed. We always start with something kind of less severe. The prescription level debridement agents can be really harmful to healthy tissue. So that's something that you need to consider, especially as that necrotic tissue starts to come off and you're kind of seeing this very heterogeneous wound bed where there's places of necrotic tissue and places of healthy tissue. And also, as you begin to debride, the wound itself may get a lot more wet. And that's something that you need to consider when you're talking about those outer dressings.
Could you maybe give me or give us like an example of sort of I almost think of like this reminds me of steroid potency, right? Like there are different potencies of almost debriding agents that you like to use. Like could you maybe give an example of like a high, a medium, and like a low potency item that you would consider for debridement?
That's a tough one to answer. And oftentimes it's about what the wound itself is going to respond to. So my go-to is always to start with something like a Meta Honey, which is pretty gentle, has a lot of great properties to it. But if the wound is not responding to that, I'm just going to switch it to something that is also non-prescription, such as like a hydrogel. But again, we're wanting to talk to our clients about what they can and cannot tolerate. There's a lot of people who can't tolerate hydrogel right now, so that may not be an option. There's solutions such as FASH that are more liquid. Again, talking to people about accessibility and if they can tolerate that on the wound. And then there's prescription level debriding agents such as Santal. And I feel like someone wants to jump in here and talk a little bit more.
Santal, it's collagenase. So it's like
Yes.
a enzymatic debridement agent. But you need a prescription for it. Oftentimes, if you've had to write a prescription for it, you have to measure the wound and then call the pharmacy and then get a prior authorization. So it takes a number of steps to get it to the patient, and sometimes they can't afford it. So I work in a certain service program wound clinic, and we are often dependent upon donations of whatever equipment we have and ointments we have. And so sometimes when we don't have medical grade honey, we have to resort to just using things like emollients like petrolatum or, like petroleum jelly. You can get it at a dollar store. And the goal, again, is to moisturize the non-viable tissue, which is often like eschar, so that it automatically falls off over time.
And are you doing any I know you mentioned like a little bit of mechanical debridement with the cleaning of a wound, but are you doing any more extensive mechanical debridement?
No, we really want to protect that wound bed as much as possible, and kind of forcing that necrotic tissue off before it's ready to come off can really damage the wound bed underneath and actually prolong wound healing.
How often do you have to apply the debridement?
Yeah, we recommend doing it every single day to cleanse the wound and apply that each day. One, because we want to kind of take off any tissue that has actually become non-adhered and has broken down, but also just generally keeping that wound clean is ideal. And then from there, just assessing whether or not it's working. So getting a daily kind of check on, is whatever I chose working or not, and do I need to get something prescribed such as a Santal is going to be something that we can do on a daily basis. The wounds change very quickly when they're getting treated with these kind of like agents that are a little bit more than, say, an A&D. I think something that we do really need to talk about often is just accessibility. I'm very lucky in Boston to have as much access to kind of more specialized wound care supplies than many other places. When we're doing trainings, when I've been at conferences, it's really opened my eyes to how much access we have just within the small area where I work. There are multiple low threshold sites. But if you go outside of our small area, that accessibility drops completely. So talking to people about, hey, this is the best option when you see me, but if you can't get it, going to the grocery store, going to Walgreens, wherever, and getting A&D and putting that on your wound to keep it safe and clean in between, you being able to access these more specialized supplies, it is super, super important.
And I echo Tehya. I think the other thing as providers is to know what your local resources are. So oftentimes you will have local certain service programs, harm reduction organizations, mobile vans, outreach teams that have access to some of these ointments and gauze and whatnot. So if you are in a clinic or you don't have these, knowing what your local resources are, where your patients can actually go is really important. Because if you have a really large wound, you're going to go through wound care supplies quickly, and it is very costly.
And so I know we got through the cleaning and then putting some sort of debridement on it, thinking about kind of the next steps in caring for the wound. What are you covering the wound with? How are you kind of protecting the surrounding skin?
Yeah. Going back to kind of that, is this wound very moist or not moist? Is there a lot of drain and not drainage is key. So if I have a particularly drier wound, I'm just going to be applying that debriding agent. I might put something like an adaptic or even a layer of A&D just to keep things from sticking to the outer dressing. And then I'm just going to put like a non-stick pad on top. If it's draining a lot though, I'm going to think about using an ABD pad, or if you have access to that like specialized foam, if it's like really, really draining. But again, those are expensive wound care supplies. So even just something like Curlex, which is just a roll of gauze, really adding quite a bit of a layer of that is going to absorb a decent amount of drainage. And then from there, we want to think about the very outer dressing. Something a lot of people use is Coban. And Coban, I adore Coban. I have for a long time used Coban quite often, which is that like really sticky kind of like, I'm not even really sure what it is.
Like what they wrap your IV with.
Yeah, like that elastic kind of outer dressing that sticks to itself. The only issue with that is that it's compressive, and then it compresses further as time goes on. So when you're using this, it's key to be asking people, like, does this feel tight at all? Because if it does, you want to take that off and you want to loosen it up. And you want to be using it kind of beyond the borders of the wound. Like oftentimes people will just dress a wound where the wound is. And we really want to be going further out from that so that we're not getting trapped swelling on either end, below or above our Coban. Ideally, we've been using ACE bandages, which have a little bit more flexibility, are a little less compressive, and are much more breathable. And they work wonders. Also, in general, these wounds tend to be very tender, quite painful, and that goes for the surrounding skin as well. So having something that's like super compressive on your arm is really not ideal.
And I know you mentioned recommending daily changing of the dressing, it sounds like, to clean and apply these debriding agents and all of that and keep the wound going. Is that something that you're seeing folks in clinic on a daily basis? Like, are people doing this themselves? How are you kind of negotiating how often folks are coming in and how that goes?
That's up to them. That's always my first question for them. Like, when's the last time I saw you or you saw anyone? And when is the next time you think I might be seeing you? And no matter what they say, I'm also going to be assuming that that might not be possible. And they may say, I'm going to see you tomorrow. And things happen and they may not see me for several days. So I'm always giving enough supplies for someone to do their own wound care, covering the amount of time that they said that between when I'm going to see them next and when I'm seeing them currently, but also giving them a little bit extra just in case. Again, we are very lucky to have the capability to do that. So if it's going to be a long time, say it's going to be a week out or something, I'm giving them a lot extra of the A&D, those ABD pads, are kind of really basic wound care supplies just in case they run out of the specialized stuff. But yeah, it's really about talking to the client and letting them guide what you're doing.
And sometimes your patients are much more comfortable having somebody else do the dressing. It's painful. They need pre-medication. And so making sure you're talking to them about like, well, even if we don't have an appointment, like, do we have urgent care hours? Do we have a low barrier wound care place where we can have you go and get your dressings changed? And so I think like offering different examples of where people can go and options is really important, because this is wounds heal, but they heal over a period of weeks to months.
And is there like, so you've done this and kind of debrided the Eschar and the slough and all that stuff. How does it just then you go to like vitamin A and D ointment, and or like what changes after that?
Yeah, as you start to see more healthy tissue, A&D is excellent. It can go on the wound. It can go in what we consider the peri-wound area, which is kind of that surrounding skin outside of the border of the wound. Technically, it's 4 centimeters out in all directions. And protecting this is as important as treating that wound bed. So A&D is excellent. There's some specialized wound care supplies. So when we start to see healthy granulation tissue within the wound bed, as long as it's not too dry, you can do something like a calcium alginate. I often suggest, if you are using a debriding agent such as Santal, where getting that into that healthy tissue can actually damage the tissue surrounding the areas of necrosis, where there is healthy tissue with something like a calcium alginate that's going to promote healing and protect that tissue can be a good strategy, especially before you put the debriding agent on top.
So as Tehya mentioned, wounds evolve over time. And so having touch points on a weekly basis or even every 2 weeks is important because your strategy and your management of the wound might dramatically change as the wound is healing or gets infected or has periods of non-healing or whatnot, because it's not a linear sort of healing process for a lot of patients.
Something I'm doing too the whole time I'm doing wound care is talking to the patient about exactly what I'm doing. I'm talking about exactly what I'm putting on their skin, why I'm putting it on their skin, if it looked different, what I would have done instead, so that when they are doing wound care on their own independently, they have that knowledge and they're getting it each and every time we do a dressing change.
I will say self-care is really key. So again, whatever you can do to support people to manage their own wounds, not only just giving the supplies, but also walking through, doing a teach back, checking in on like, how did it go? Well, last time we talked, did you run out of some of the supplies? What went well? Like, how can we help you? Those conversations are real important. And then also talking to patients about like, when self-care is not going well. So there's some like best practices of things to avoid. So using things like alcohol and peroxide and those you'd probably think about more for abscesses, but they're probably not helpful for these delicate ulcers that those agents are too caustic for those wounds. And so dispelling some of those myths of like what we think are good practices for wound care, are also good things to talk to patients about.
And Ragini, you'd mentioned like some patients for needing pre-medication. I guess thinking about how painful, both of you have touched on how painful these wounds can be for folks. How are you guys handling that kind of pain control, especially around dressing changes?
It's really difficult. I think a lot of our patients have to self-manage with localized sort of continued use because of the pain. But again, giving them autonomy to be like, what is going to be helpful, making sure you're maximizing your non-opioid analgesics, and then giving them at least 20, if not 30 minutes before you're going to be doing a dressing change is important. Some of us use full opioid agonists as well. This also is really important in the inpatient setting, that when you're putting in your orders and working with the wound care teams, that you are like putting in PRN before wound care to get analgesia, because there's nothing like riffing off a dressing that can like push somebody over the edge and then want them to leave the hospital and not trust the care that you're giving.
I have a number of patients who, as you said, kind of elect to continue to inject in the site. So 2 questions: any brief harm reduction tips on for folks who elect to continue to do that practice? And 2, even if people switch to smoking or some other form of delivery, can you still get these wounds if you're not necessarily injecting xylazine?
I think anecdotally, we've had patients who've done route switching as a harm reduction strategy. So saying like, okay, if I inject, like get these wounds, I'm going to switch over to smoking and snorting. But then some of them develop other harms. So we've had some patients who are chronically snorting, developing nasal ulcers and having sort of sinus issues. So talking to folks about that, there is potentially not a safer route of use in this case, but I think you have to acknowledge the fact that if people would have to sort of self-manage their pain, like how am I accommodating my dressings to help them so that we're not occluding like the one area where they're actually able to get some pain relief. Exploring, can I actually help you find another place of venous access? So we don't really do a good job about this, but like whipping out a tourniquet or a vein finder in your own clinic and helping your patient find another venous access is really important. Talking to folks about wiping the needle of any drug after they have aspirated the drug in case there's any of the adulterant or other irritants on the outside of the needle is another harm reduction strategy that is being used in the community to try to minimize like subcutaneous inoculation of that adulterant. So that's another harm reduction strategy. I think also talking to people about how can we give you full opiate agonists in addition to their MOUD is another great strategy,
Yeah, I'd like to say that this is like a really important place to talk about advocacy for safe spaces for people who use drugs to be able to use. That when we talk about overdose prevention sites, allowing people to be in a space where they don't have to rush, where they can utilize the harm reduction strategies that we talk about all the time with them, that are really, really difficult to do when you have police watching over you, when you are outside in the elements. If we're not talking about providing those safe spaces, there is only so far that we can expect anyone to be able to utilize the strategies that we talk about and that they really want to be using.
I've learned so much from both of you today. I feel like I'm ready to go out and apply these newfound wound care skills. Before we jump into sort of like take homes, Zena, Sean, anything else? Any other questions y'all think we should ask our guests?
I guess just quickly, is there ever a time where you would refer to like a plastic surgeon or other wound care specialist, or is that less relevant for these cases?
I think that sometimes patients will have wounds that if there's evidence of necrotizing fasciitis, like that's something that they need to be admitted in the hospital for. And the clinical management for that is surgery and debridement for source control. But, the more you can manage as an outpatient, it's really helpful. I think we've heard from surgeons who were doing more aggressive surgical debridements before, and they've really shifted in their practice to try to encourage conservative management first. We know that that seems to help people heal better. It helps with pain management better. But there are instances where patients have healing, they have granulation tissue, but maybe it hasn't fully granulated over, or maybe there's exposed bone or tendon, and that's vulnerable to infection. In those cases, it would probably be a good idea for people to be considered for skin grafts and whatnot. And that's really where we'd get our plastic surgeons involved. But I defer to, your wherever you're working, because I think this is an evolving field. And I think the surgeons are learning at the same time as the medical providers on like how to best manage the risks and benefits of these wounds and facilitate healing.
Yeah, I mean that's really good to know too. I think I'll say I think this was really empowering as hearing. I mean, I probably have the same kind of reaction as a lot of people who don't have a lot of wound care experience. You see it and you're like, holy crap, I'm never going to be able to fix this. And being like, oh, wait, there are things I can do to help people. And by me offering it as hopefully the person listening to Curbsiders Addiction Med and offering MOUD and all the other great stuff, prep that we can do, can really both kind of engage people, get them keep coming to clinic, help them with the things they need help with. And so this has been really awesome. I mean, even for me, so probably for everybody listening too.
All right. And on that note, the hour is getting late. So I would love to hear some take-home points. Let's start with you, Raagini. What take-home points do you have for our listeners?
Safe supply. It's my take-home point. I think it's we wouldn't have to do a Curbsiders on xylazine if we had a safe supply. And I think that, it's unfortunate that we're having to sort of learn from our patients suffering from these clinical harms. And so I think there's a real point of advocacy for all of us as addiction specialists and people interested in addiction to go to our powers that may be to advocate for our patients, because I think that we need more drug testing and safe supply for folks to be safer. But I think the takeaway about wounds is that they heal, but they require longitudinal wound care, and we can do it. You do not need a certification for this. These wounds can heal. They need supplies, empathy, and a little bit of time.
I love that. Supply, empathy, and time.
And Tehya, any additional take-home points to add?
I think my big take home is always that this is a partnership. It's a partnership with the person in front of you, and taking that time to really trust build and relationship build and teach are all ways that we can help engage people who use drugs who really, really have experienced just some of the worst things I have heard in our medical system. And it's our responsibility to turn that around and to provide good care and to just, make people comfortable and feel like they're worthy of the care that we are trying to provide, so that they are able to come back in and we see them earlier and we see them sooner. And these wounds hopefully will take less and less time to heal as the years go on.
And we'll go in reverse order. Tehya, is there anything you want to plug? It could be anything. an organization, a book?
Just your local harm reduction organizations. They are who are on the ground doing the work. And, I have learned so much I started in advocacy before I even got into the work that I'm doing on the ground as a nurse and nurse practitioner. And the people that I worked with doing advocacy, the advocates who have been in harm reduction for literal decades, we need to support them. They are marginalized and they are under-resourced, and they deserve much more respect than they are getting.
I second that. I think we have experts, and they're the ones who've been doing the work, helping people heal their wounds, helping keep them safe. And oftentimes we don't spend enough time with our local harm reduction organizations. So if you have the opportunity, connect with your community partners, figure out who they are, and shadow them. And if you don't know wound care, you will certainly learn wound care if you do street outreach, or work in your local SSP. I think this is the time where we need to get rid of our silos in how we do addiction treatment and harm reduction.
Well, it was an absolute pleasure having both of you here today. Thanks so much for joining us and teaching us about wound care.
Thanks.
Thank you so much.
This has been another episode of our Curbsiders miniseries, the Curbsiders Addiction Medicine. Get your show notes at thecurbsiders.com/addiction.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at curbsidersaddictionmed@gmail.com. A special thanks to Dr. Matt Watto and Dr. Paul Williams for their support in this project, as well as ACAM, the American College of Academic Addiction Medicine. Learn more about the organization at acam.org.
A very special thanks to our writer and producer for the episode, Dr. Zena Huxley-Riker, and our editor, Dr. Pyle Roy, and our entire team in general. The Curbsiders is produced and edited by the team at Podpaste. Until next time, I've been Dr. Carolyn Chan.
And I've been Dr. Zena Huxley-Riker. Thank you for joining us today and letting us bring you some addiction medicine pearls.